Another test that we utilize under the lipid components for testing, we talked about the APO, A and B, particular ones that help us with usually cardiovascular risk assessment. Another one is LP little a, okay? And it's part of APO little a. They get pretty confusing, but I think this is all of them, okay? So we had APO big A 1 and APO big B 100 that you need to understand what those are, and we do test for those. This one is part of the B100. It resembles plasminogen. Do you remember that from hematology? Yes, I remember that exactly, and what it does and everything about it, right? Okay, it is part of your coag system. It is very thrombolysis inhibitory, okay? Prevents clotting. And it is used for cardiac heart disease or coronary heart disease and stroke assessment. There's another one that is PLA2. And just know those four. Don't have to get into a lot of details about them, but we mostly use them for clots, where we're clogging up, which is related to lipid assessment. You hear all about cholesterol, but you don't hear about the rest of it, but they're all related. Hyperlipidemia. We don't need to worry about low lipids, but in your textbook you have a box with risk factors and just a few things that I want you to get out of hyperlipidemia, okay? The lipids that we actually measure are your triglycerides and cholesterol, and then the lipoprotein of HDL. We do a calculation for LDL. Does anybody remember what that formula is and what it was called? You need to have this one memorized. Free-to-wall formula. Your total cholesterol minus, in parentheses, I'm sorry? Trigs. Okay, and make sure you do the math correctly. Trigs over 5 plus HDL is going to be taken away from total cholesterol. And just think of it as total cholesterol is everybody, and we're subtracting parts of them. A fifth of your trig is supposed to be normal portion that is your very low VLDL. So that leaves LDL. So you're just subtracting everybody else in this formula, and it's supposed to leave the portion of cholesterol that's LDL. And LDL is bad. Some people use the word lousy for L. We don't want it to be elevated. I don't have it on here. We want, and there are a couple different groups, agencies that came up with some figures, target values for your lipids. I don't expect you to keep them all straight. But like in a question, I might list a name of one of the agencies and say they recommended your LDL needs to be what, okay? And on the forms, when we result them, on the patient's form, it's broken up into acceptable, borderline, and high risk, and sometimes even more so. Okay, so most of us are not what they call acceptable, and LDL needs to be under 100, and most of us are not in the American population. So they give us a little grace period and say, well, up to 150 is borderline. or approximately. Just know that LDLs, you want them to be low. The lousy LDL, you want to be low, because the higher it is, the more you're going to cause problems. Do you remember the main function for LDL from last week? It's a truck, and it's taken excuse me, trig and cholesterol, taking lipids to tissues and dropping it off. That's why it's bad. If we don't have very much of it, it's not going to transport it and drop it off to create plumbing problems. Okay, and in particular, elevated trigs. Basically, you have the same problem if it's trig or cholesterol. One thing I want you to realize with elevated trigs, it's off of your immediate ingestion. That's why we need the fasting. Cholesterol is not significantly elevated, fasting or non-fasting. There's not enough change to have to say we've got to have a fasting for cholesterol. But triglyceride it's your first ingestion. It's the first form of it. So we do want a long-term fast, like a 12-hour fast, which is a little longer than like cholesterol, or excuse me, glucose. We like an 8-hour fast for glucose. And if you look at the serum after you spin it down, just by the color, or what you're going to see, it's not really color, it's appearance, you can kind of predict what your trig is going to be. And when we did phlebotomy, I could always have some good samples for you, but I don't have any right now. Normally when you're fasting, it's under 200, usually under 100, and it's nice and clear, which is what we expect our serum to be. But if we have just ate that Big Mac within the last few hours and we come in and get it drawn, it's going to start being hazy because we've got trigs in our serum, in our bloodstream. So if you see hazy, off the bat, you're going to think this is not fasting. And for the most part, they're not. However, if it is a true fast, a 12 or more hour fast, and it's hazy, that is a metabolic condition. And it is significant. So we do note for the physician if we see haziness, and then they kind of determine, if they drew it at 2 o'clock in the afternoon, they usually just assume it's a non-fasting. If it gets even higher, if we're getting up to 600 levels of trig, that's not from ingestion. That's a major metabolic issue. Got some liver problems going on probably, and it looks a little milky. I think I had a tube for you last semester that had a lot of lipids. It kind of looked like skim milk. It's got a little yellow cast to it because our serum is normally yellow. That is extremely significant, okay? They definitely have some metabolic issues going on that you need to note with your results, the appearance of that serum. A lot of our instruments, we are concerned, and this is a side note, we're concerned with hemolysis because the rupture of the red cells releases elements that are falsely changed then, usually elevated. So that is one we can control. If we see a hemolyzed specimen, what do? Reject and recollect. It's rare when it's intravascular. And we talked about that, I think, with the proteins. Ecteric. Remember what it looks like? It's kind of an orangey, almost a fluorescent. Ick. I call it ecteric. It's icky. I don't want to touch it. You think of like your hepatitis patients. They have some liver problems going on, and it's from your bilirubin. So can we do something about that? Nope, that's a condition with the patient. And then lipemia. And these 3 components are called indices. And our chemistry analyzers, the larger ones, they actually do a spec view of the appearance of your serum, and then they grade it. Some of them actually give a number, some of them will say 1 plus 2 plus 3 plus, and give you that information as part of any test that's ran on it. So it's tagged to the answer. I got a potassium of 6.0 with a 3+ hemolysis. That, and you don't know this yet, but that tells me it's falsely elevated because it's hemolyzed. Lipemia will also be attached to that. We can do a little bit about the lipemia. If we treat the serum, we can get rid of that lipemia. You know, it's cloudy, so the effects of the light beam going through to read any test can be changed enough to make it significant. So if we can get rid of those particles that are floating around in there, that's better. And there's different ways that you can get rid of it. But the simplest way is if you spin at really, really high speed, fast and hard, you can obliterate or spin them out, so to speak. You've been on the ride, you know, like the centrifuge I told you about, where you stand up and it kind of pushes you out and you go in a circle and they turn it sideways. Think of that, a centrifugal force. But it's not your typical centrifuge. It's called an ultrafuge. And you put your sample in a little container and it spins the lipids out, and then you can pipette out the clearer serum. It just depends on how much lipemia is there, how clear it's going to be, but it's going to look a whole lot better. And then test that. Well, obviously you can't test lipids because you just spun them out to the sides. So often those patients, you will have a pre-sample to run your lipids on, and then the ultracentrifuge sample to run everybody else. And one of my students was able to bring me one. This ultrafuge is only like this big, but it's attached to a pneumatic line to give it really high speed, and you only spin one sample at a time. It's got a hole here. You're going to need a very fine tip pipette to put your sample in, kind of fill out this outer well, and then it goes into this big locked up thing for one sample, and it gives a real high pitched sound when it's spinning. It takes a little while because it has to get really, really high speed, and then it comes back down. And then you remove it, and in the center well, you can actually pipette out your cleared serum. Okay, so if you see or read anything about ultracentrifugation, that's what we're talking about. And that's how we'll get rid of this lipemia that's going to interfere with non-lipids tests. If they don't have that, there are some chemicals you can actually treat it with. That's not ideal because you're adding a chemical, so you can't just add anything. You got to be careful, and sometimes there are limitations on what tests you can and cannot use this on. But if you are at a site and they have one, be sure to get to see it, check it out. You might not have any lipemic patients while you're there. We don't get them very often, thank goodness. Usually it's the same people, handful of people that are having problems. These are the reference intervals that I want you to know. And see here, it's saying your total cholesterol should be under 200 and that it's not significant elevation after ingesting. So it does not have to be fasting. So triglyceride is the one that needs to be fasting. And here are the values. They've got 4 categories. High and very high. When you are borderline, as you approach 200, your doctors are going to start fussing at you. Oh, we need to get you on some meds. Same thing with cholesterol. But look at this one. We want HDL. He's the good guy. We want it to be high. LDL we want to be low. And we actually they want us below 100, but most people are not. They want HDL, the good one. We want a lot of it. Our test methods normally cannot measure above 100 milligrams per deciliter. So when you get up to a certain height, it'll just say greater than. So even if you have elevated total up here. Say you've got 250, and your doctor starts talking about getting you on some meds. They need to look more importantly on these two. So if you've got a 100 LDL, that's good. And you've got a 30 HDL, that's not good. So maybe we need to start thinking about it. Probably your LDL would be higher than 100, probably be more like 200 with that low of an HDL. But if you have an elevated total cholesterol and you have an elevated HDL, you're probably okay, because what does HDL do? You told me what LDL did. Back to the liver for discarding, mostly, okay? So we want a lot of it. So if we've got a whole bunch of HDL and our total is not too high, we're probably okay. So sometimes our physicians only look at the total cholesterol. They're just assuming it's all bad. Well, you know, there's a big chunk of it that's good. So a lot of it has to do with genetics, how you're made. If you have a lot of LDL problems or elevated lipids in general in your family history, you probably are going to have that too. And that's where the medications can help. There are some people, it doesn't matter if they never ate any cholesterol or fats, they're going to be lipemic. And their body is making it. So they interfere with the medication. My mother used to work with a young lady, and she was only in her 30s, and her serum looked like whole milk. It didn't matter what they did. So eventually, you know, her liver is going to be shutting down. She's going to be clogged up all over. At such a young age, they could not get it down. It was her genetic fate. So know these values, and the Friedewald. Do realize it's only applicable with triglycerides under 400, okay? Once they get to over 400, there's too much to use this calculation for. Remember, it's just an estimate. We're mostly trying to figure out how much is the very low density that we don't even measure and subtracting it in HDL to leave the LDL. So when your lipids get really high, well, you've got a lot of chylomicrons in there too, and we're not accounting for that, so we can't use this calculation when our trigs are too high. Do know some of your methodologies, and we're going to talk a little bit about some of this today, and we'll help clarify some of it. But cholesterol oxidase is the most common enzymatic testing that we use for cholesterol. We can use the very same chemistry if we treated our serum to get rid of the LDL and the VLDLs that would leave HDL, and that's how we actually used to measure HDLs. We treated the serum to get rid of those other two, and that left HDL, and then we measured it again using the same methodology, okay? We are looking for peroxidase. We're going to add a dye and get a color. A triglyceride method is going to take the glycerol and add, remember what triglyceride was? It had your glycerol and your 3 fatty acids. Okay, so we're interrupting that and coming up again with peroxidase and a dye for a color. Oh, and I kind of already talked about this. The HDL ultracentrifugation is the best way. We can do electrophoresis. We talked about that, where we migrated all the classes, and then we could stain them just like our protein electrophoresis. That's where we first started, talking about the density of them. Those are ultracentrifugation, not everybody has that. It's an expensive piece to have, plus you got to have the plumbing for it. And electrophoresis is very time consuming and technique dependent, so that's not a good answer. Then we came up with this precipitation where we added dextrane sulfate. It was a pretreatment to the serum, centrifuged it, and it got rid of these two fractions. So what was left in the supernatant was considered just the HDL. Well, that's also time consuming. When you're doing 100 lipid profiles a day, that's a lot of pipetting. You ran all your trig and cholesterol, then you had to pipette serum out and treat it, spin it, and then put it back on the analyzer for the other cholesterol reading that gave you the HDL. And so we had more errors because we had a lot of human intervention there. And then we finally came up with a better automated system that is directly going to bind those up in the tube and then just measure what's left, so we don't have our pipetting. Okay? But they say the reference method is to do kind of all three. Ultracentrifuge it, then precipitate out the rest and measure it. Okay, we already did this. Metabolic syndrome, and we'll talk more about metabolic syndrome, but these are the conditions a person doesn't get into right away. They gradually start adding them, but cholesterol and glucose. So we have a high LDL and trig and glucose, and usually there's some hypertension. They're starting to plug everything up, so they get sluggish. Elevated glucose, diabetes mellitus, they started having lipid problems. So they'll start with their glucose elevation, and eventually they'll have elevation in their lipids. Okay, so that's why diabetes mellitus is more of a group of conditions. It doesn't just stop with the glucose, but that's where it starts. So the only thing that's low is the HDL. And this puts you in a high-risk category for metabolic syndrome.